Welcome to an introduction to asthma in the pediatric patient. My name is Somaili Vela, and I will be presenting a short lesson on what asthma is and its pathophysiology to a group of nursing students. So, what is asthma? Asthma is a chronic inflammatory disorder of the airways characterized by recurring symptoms, airway obstruction, bronchial hyperresponsiveness, and an underlying inflammatory process. Signs and symptoms of asthma include wheezing, chest tightness, cough, and shortness of breath, triggered by a variety of stimuli in varying degrees of severity. Asthma is often classified into four categories: intermittent, mild, moderate, and severe. Asthma is the most common chronic disease of childhood, being the primary cause of school absences and the third leading cause of hospitalizations in children younger than 15. Though the onset of asthma may occur at any age, 80 to 90% of children have their first symptoms before the age of 4 or 5. So let's talk about the pathophysiology of asthma. So the usual cause for asthma is contractile hypersensitivity of the bronchioles in response to foreign substances in the air, which then produces impaired respiratory function. Then the increased resistance in the airway causes forced expiration through a narrowed airway, and the volume of air is trapped in the lungs will increase. So this trapping of gas forces a child to breathe at higher and higher lung volumes. This makes it more difficult for the child to breathe, while the inspiration occurring at higher lung volumes hyperinflates the alveoli and reduces the effectiveness of the cough. This decreased respiratory effectiveness eventually causes the child to become more fatigued and have increased oxygen consumption. So, for treatment options, your best treatment is to avoid triggers such as allergens, infections, tobacco smoke, obesity, cold air, and anything else that seems to bring on an asthma attack. However, if certain triggers are hard to avoid, the implementation of inhaled corticosteroids for long-term management and rescue medications will need to be used. These are prescribed by a physician or a nurse practitioner and are often given via a nebulizer or a metered dose inhaler. So, according to an article that I read by Gans and Gavrilova, there was a study performed in which specific asthma endotypes would be determined depending on asthmatic's biomarkers. This would in turn lead to a better understanding of which specific triggers would result in asthma attacks for specific individuals, helping them to avoid exacerbations. 3 differential diagnoses for asthma would be bronchiolitis, croup, and epiglottitis. I have focused mainly on the pertinent negatives of these diagnoses. In bronchiolitis, this disease usually occurs in children up to 2 years of age. Bronchodilators are usually not effective, and they tend to be caused by a viral infection. While in croup, this is normally seen in children up to the age of 4. Inspiratory stressors usually noted upon crying or activity. Hoarseness and barky cough are normally present, and this is an upper respiratory infection. As for epiglottitis, drooling is normally seen. Stridor worsens on supine. Dysphagia is present, and airway obstruction can appear suddenly and require emergency intubation. So, a few things to think about. So the best therapy for a disease process is always all-encompassing, and that includes education, environmental control, pharmacological management, the use of objective measures to monitor the severity of a disease. So the goal of effective asthma management would be to become more informed about the specifics of the disease process, including avoiding triggers, appropriate use of prescribed medications, being monitored by a pediatrician or pulmonologist regularly, and educating your patients and their families about all of this is key. So always keep in mind that effective management is the goal with a chronic disease. And these are the references.